political economy and health inequalities, as well as behavioral health economics. Right. So I do work both in high and middle income, low income countries as well. And just actually last week, we were looking at similar data to the one that I've seen that we will be discussing later today about an increase in maternal mortality in the US. So, I mean, this problem with maternal mortality is not just a problem of low-income countries. I mean, the US is actually exhibiting an increase, and I think Canada has a similar trend. I mean, a bit less intense. So it seems to be like a problem across the board. We don't see it in Europe. In Europe, we see the opposite trend. We see that maternal mortality is almost not there. No, I mean it's actually fading as expected. Quality of care, which is a proxy for quality of care. So I see that we will be discussing quality of care today, and yeah, I'm very excited to participate. So sorry for the long introduction.
No, that's great. And I figured I asked all of you to send me your questions, and we received at least one from Team Homa Bay, where they are asking, actually kind of pointing in your field, a broad field of expertise. They're looking at health economics and asking for local authorities in low and middle income countries who are responsible for providing healthcare and struggling with lack of financial resources to improve the healthcare system. Could you elaborate a little bit on this and how to kind of look into ways of having better financial resources? Is it possible? Can you restructure in any way? What can you do?
Yeah, so on the resources, I would say that's not really an issue with the health system or health economics. This is probably a broader issue about the efficiency of the state, right? So in Europe, we tend to have like states that are quite efficient at raising taxes. I mean, only in Sweden, for instance, if I remember well, you almost spend 1% of the GDP in making sure that people pay their taxes, right? So in inspectors and making sure that, I mean, people would pay their taxes anyway, but there are penalties out there, there are civil servants in place in order to make sure that the expected tax revenues are raised, and on top of that, there's very little corruption, waste, right? Whilst what we see in low-income countries is the opposite. We tend to see that the tax bases are very difficult to build. Tax instruments are not optimized. Often, one of the main problems is that a significant chunk of the population might not be working on the formal sector, so then that limits the capacity to raise direct taxes, because then all you can do is sort of raise taxes on consumption, so long as they pay VAT indirect taxes, right? So that limits actually the capacity of the state to raise resources to then invest in healthcare, right? And then even if they have the resources, in some cases, healthcare is not seen as a priority. There are other priorities that take precedence that typically they take a higher priority, let's say. So often healthcare programs are not high in the agenda, right? So that's another problem with lower and middle income countries. On top of that, local taxation is quite limited, and it's so local authorities in lower and middle income countries have limited capacity. So that's nothing to do with the health system. It's more like about how to build that fiscal capacity that I would say is not there in many low and middle income countries, right? And I think that as a priority, that should be perhaps the first objective, right? So now, assuming that there is a fiscal capacity and that there are some fiscal resources, some tax revenues to be invested in programs, and the question here is, what are the most important services to implement? And in fact, now we are writing a report for the WHO. And one of the arguments here is that in the same way as we have a list of essential medicines that every country in the world should have, there should be a set of programs that every country should have, right? So there should be like a list of essential programs, health programs, right? That every country, every local authority should prioritize. And that is not there. So we don't know what it means, quality. Quality is just an abstract concept that is often very hard to measure. And that is great because politicians, when they when they are confronting with this kind of abstract concepts, they always find a way to not to deliver, right? So I think that one way to address that is actually listing what are the key programs that we would expect governments at different level of government, local authorities, regional governments, national governments, that should be delivered in the same way as the WHO goes when develops a list of essential medicines. Right? So we should have that list. And then, of course, often the question is that those programs might be there, but the quality in the delivery of those programs might not be the one expected, right? And when it comes to healthcare, quality can mean two things. One, it can mean like the perceived quality, which might not be as high as expected, and that can be picked up by satisfaction surveys, or the objective quality, which basically means how many people die in hospitals, for instance, right? So objective measures of quality, which are basically measures of health outcomes, right? And this is quite straightforward to measure. And maternal mortality, for instance, is an example. I mean, this is an indicator of how well the health system is working. Maternal mortality, when Britain introduced the NHS, or probably Sweden introduced its own dropped dramatically, right? So that's the kind of thing that we see when a health system works, that no woman dies when delivering, or almost no women, so nobody dies, right? And that's a measure of objective quality. And what we see is that in low and middle income countries, that's not true. There's still significant share of the population that dies actually when delivering a child, which is quite sad, and this is something that can be addressed. We know that can be addressed with better investment, right? And what we are seeing is that in the US is actually increasing, and in part the problem is because they are not investing enough. I mean, as you know, the US has a significant share of population that has no insurance, so that is actually a problem. So countries that have no universal healthcare tend to show higher shares of maternal mortality. Right? And then more generally, quality of care, as I was saying, it's very difficult to measure, but one could establish like some measures that could be tracked over time, right? I was actually reading the paper that you circulated in the email about how to engage people to go to hospitals. So if we want to reduce maternal mortality, what we would want to have typically is women to go through several checkups before delivering, right? So if there is a problem, that problem should be identified early enough. So screenings, right? And those screenings are not happening in many countries because there's no investment. And even in Britain, I mean, pregnant women would go through 2 or 3 meetings with not even the pediatrician, with the obstetrician perhaps, or the nurse before delivering a child, right? Only 2 or 3. Well, why don't we see that in countries in Africa, right? So why don't we guarantee to women a certain number of screenings, a certain number of checkups before delivering a child, right? And that's not there. And of course, the question is how to engage women with the health system. And there's different ways to go. One would be using kind of cash incentives and things like that. Other, because we are in a context with limited resources, that's what I heard a minute ago. One could employ methods of behavioral economics, or nudges. And typically that means trying to piggyback, for instance, screenings with other activities that women would do in their daily life. So every time you go, so perhaps one way to go would be to move the hospital to the villages. So create like more like transitory hospitals, right? So mobile hospitals that would go to the different villages, right? And that they would make sure that women are checked before they deliver, for instance, right? I mean, another thing, if we were to discuss quality, would be, for instance, to create some kind of like lists of towns or local authorities in terms of how well they are doing when it comes to delivering quality, right? So this is what we call yardstick competition, right? So we want to, I mean, normally towns, villages, they don't want to be worse than the next, the neighboring village, right? Or the village across the country, right? So they might actually want to compete in delivering the same quality, right? And then another important point is how to engage politicians in delivering quality, right? So citizens in the country need to be able to judge their politicians in terms of how well they are delivering those quality goals to their citizens. And that is not happening because, as you will know, there is quite a lot of corruption. People vote purely on loyalty or racial ethnic identity grounds, as opposed to the way we vote in most European countries, which is we reward politicians that do well and we don't reward those that don't do well. In many low-income countries, people vote along the lines of ethnic identity, and that's all they care. So then the politics is useless then. So it doesn't deliver, right? I see there is a question. Ingvar, I think, yeah. Hi.
Thank you. Do you hear me?
Yeah, I can hear you.
Thank you. I'm representing Homa Bay, and I would like to include also my partners in Homa Bay County on this question. But I'm happy that Felicia raised our question, and we formulated it like this, just to go back, because you provided a lot of information on the problems and so on, but we are looking for the solutions. So we describe it like this. What would you as a professor say to local authorities in low and middle income countries who are responsible for healthcare, who are struggling with the lack of financial resources for improving the healthcare system? What kind of research are available for local authorities who are struggling with these challenges? Research that analyzes how local authorities in low middle income countries can improve their economic status and management of financial resources for them to improve the healthcare system. And our question is strongly connected to at least two of the ICD's core values when it comes to equity and accountability issues. And in Homa Bay, these questions are of great concern, because capacity building is very, very important. But the underlying challenge is also a lack of resources and how to improve the whole system of getting financial resources to the healthcare system. And we're trying to find a way to communicate with ICLD and with research to actually find some good answers on this, because Homa Bay is doing tremendously well for a short period of time. And in Kenya, there has been a devolved government that have put up a new decentralized system, which makes the counties more responsible and accountable for the healthcare system. And this is quite a new system for them. So we're trying to do our best to support each other to find good answers, because the problems we know very well, but what are the answers? So I hope Francis or Gordon can tap into this discussion for us to have a conversation. And I guess all partners in the Uganda as well have the same challenges, because there lack of hospital beds and a lack of paid staff and such things. So it's a dramatic, a very, very tremendous big need for improving on this status. So Gordon and Francis, please.
Ingvar, perhaps Joan can have the possibility to answer.
Yeah,
absolutely.
So I think that, on the point on resources, there is a minimum capacity that local authorities need to have, right? So that there needs to be some basic resources out there to invest, right? So if there's no capacity, then that basically limits very much the kind of interventions that can be designed. Now, what I would say is that out of all the potential interventions out there, we know these days we have the techniques to identify those that are more what we call cost-effective, right? So there is a number of interventions that are cost-effective, meaning like they do a lot for their value for money, right? So they do a lot for their cost, right? So I would basically start there. I would identify which are those interventions, right? And actually, one very easy way to look at is that, so there is this agency in Britain, it's called NICE, it's National Institute of Clinical Excellence. And what they do is they evaluate all the different interventions that exist in England, and they compute the cost effectiveness of their intervention. So one, I mean, of course, in low-income countries, you would expect at least that they could all invest in, having like a central level, even an African level, let's say, NICE, that was to do this for their own interventions. But in the absence of that, then we could rely simply on the literature that we have out there and identify, let's say, the 5 more important or the 10 more important interventions. This was the point I was basically saying on the WHO developing a list. The same way as we have a list of essential medicines, we should have a list of cost-effective programs that are going to deliver a lot of value for limited amount of resources, right? So those should be the programs that should be implemented. Now, decentralization, I'm very keen on decentralization in Europe. And the main reason is because decentralization is a way of allowing governments to compare each other and copy from the best. And ultimately, what we see, at least in Europe, is that decentralization increases the quality of care. There is competition on quality, right? Not on price, because typically citizens don't, I mean, they don't pay for healthcare. We don't pay for healthcare in Europe, right? So what we see is that there is competition on quality. And so long as you manage to create competition across local authorities on quality, then you eventually see that quality improves. And in order to create competition on quality, you need people to either move from one local authority to another that delivers better quality. That's very hard in practice. Or through the political system. So the idea is that individuals should reward the political incumbents that deliver better quality. I just question whether that's something doable in African countries. I mean, if that's possible, if you think that let's say in low-income countries, individuals are able to reward the politicians that deliver better healthcare, then definitely decentralization would be something that I would push, because it's actually it's very much cost effective in the sense that it increases the quality of care and reasonably without increasing the cost that much. I mean, there is a bit of cost in organizing the decentralized health system, right? But then finally, there is an issue in most low-income countries as well that has to do with what we can call transaction cost. I mean, for people to move to hospitals, right? There is a cost to that. I mean, many hospitals are in urban areas, so there is a urban-rural divide. So one would require some form of improvement as well in transport infrastructure to make sure that people from remote areas are able to access those areas where the resources are, or alternatively, what I was saying before, like mobile. I mean, a solution would be to create mobile hospitals, right, or mobile units that actually go from town to town delivering healthcare in order to minimize those transport costs, right? And finally, there is an issue with engagement, and here is where behavioral incentives can play a role. I mentioned before the idea of piggybacking, right? So, it is actually what we are seeing across the board in many countries is that people don't want to screen themselves. I mean, if you don't screen yourself early on, then when they spot that there is something happening to you, it might be too late. So the question is, how do we get people to screen themselves early on, right? And I think that these mobile hospitals might be a way. Ideally, those kind of screenings could happen around the same time that perhaps there is a meeting or that there is something else happening. So I would piggyback on some other activity that is already taking place in those communities in order to minimize the cost of engaging people into screenings, right? So those would be like my initial comments.
Thank you. I don't want to take up all the space, but I asked Felicia and Robin, is it possible for having Gordon and Francis to put in their comments on this question, because they are actually the ones who really has the responsibility and work day to day with this question in Homa
Sure,
Bay?
of course, Ingvar. If Francis or Gordon would care to react on what Joan has said or add anything, feel free.
Francis?
Thank you, Gordon. Thank you, everyone. I think you have touched on some of the things that you are doing, especially the last bit you have talked about, the issues of trying to combine several activities at the same time. Like we do that a lot in terms of taking opportunities of events just to promote healthcare services within the county. In terms of accessibility, we have tried to ensure that people don't walk for more than 5 kilometers, even as they seek healthcare services. But that has come with additional costs because now we have a strain in terms of trying now to like equip the facilities to the standards that everybody would be comfortable walking in and getting all the services that they require. This would still lead people to moving from interior and coming to the urban setup because they still feel like the rural facilities are not well equipped to be able to meet their health needs. So there's still a gap in terms of financing. Our GDP is not very good, or it cannot be able to accommodate the entire healthcare system. So we're still looking for solutions on how best can we decentralize healthcare system so that everybody feels comfortable in whatever facility they are able to step in and get the services that they require. And I think that's why we're asking the question, what avenues are available for us to be able to like to resource mobilize, to be able to provide equitable healthcare in all parts of the county. The county is quite huge with a population of about 1.2 million people. Thank you, Ingvar. And thank you, everyone. Yeah.
Shall I step in? Yeah. So yeah, when we talk about equity, I mean, you know, it's like when we talk about quality, it's everything and nothing, right? So it is important to identify, you know, what are the key sort of inequalities in the system. My suspicion, at least from what I know from other countries, at least, so we've done some work in Peru, for instance, recently, and one of the problems there is basically these screenings, right? So that the fact that, you know, there are a lot of conditions that are silent, that are not visible until it's too late, right? And that creates inequalities. I mean, when people are not aware that they need care, but they do need care, right? Then they don't seek treatment, right? And generally speaking, people that are well off, they tend to undertake screenings more regularly. They have access to more regular and frequent care, right? So I guess that, you know, one would have to act paternalistically here and say, okay, there are this set of screenings. Let's say if one wants to avoid women having breast cancer or men having prostate cancer, so one would have to identify the ages at which these conditions start to develop, and then book on behalf of people screenings, right? In order for the health system to identify these problems early on when they are treatable, as opposed to later when there's very little to be done, right? So, this is typically something that is very equitable, because generally people that fail to prevent those conditions tend to be the worse off, right? So this would be an example of intervention. So anything around screenings would be a way to reduce equity. As I was saying before, mobile hospitals. So typically lower income people or people that have less resources are typically less mobile, right? So if those mobile hospitals were the areas that were to be more remote, or that are more remote, are the ones that are you know, receiving or benefiting from this mobile hospital program, if there was a mobile hospital program, then that would reduce inequality, right? So in the end, inequality basically relies, I mean, equity is about identifying those 2 or 3 or 5, I mean, potentially there's like numerous actually potential problems, right? But those 5 more important problems, and identifying who are the ones that are at a disadvantage. And here I would expect people, those would be from remote areas, individuals that typically would be maybe from ethnic groups that are not the majority in the country, so they have no voice, and typically people that would not be the most affluent in the country, and you know, prioritizing those groups, right? So that would be the way to enhance equity in the system, right? So like I said, mobility, dealing with transport and screenings. And screenings are generally quite cost effective because they are reasonably cheap. Problem is that they require engagement, but the effects long term in the health system are massive. I mean, the savings that you are making in the health system are massive, and the potential for reducing inequalities is great too. So I'll stop there.
Thank you. I see 2 hands up, and I will give the word to Helena first, because you have not spoken yet, and then to Ingvar. You're muted. Please unmute yourself.
Thank you very much. Thank you, Joan, for your thoughts. I'm just curious because I'm a doctor myself. I definitely do think screening is very valuable, but I also doubt that it's the best way to use very limited resources in a low-income setting. Definitely WHO they are guiding on the most cost-effective interventions like vaccines, immunizations and stuff like that. But I also do think more funds are needed, definitely. And I'm curious to hear your experiences of how to make politicians more accountable and how to actually make the community ask more. Ask, yeah.
Yes, shall I reply? I mean, I guess that we know a lot about high-income countries. I mean, how to make politicians more accountable, right? So, in a high-income setting, I mean, one has to be realistic and completely revolutionizing the political system in a country. It's in a country that often human rights might not be totally respected is actually difficult, right? So. I think that is going to be difficult. I mean, in terms of resources, I think donors have a key role to play here. I mean, we know that health systems in most low-income countries they survive in large part because of the money that comes from donors, right? So those donations would have to increase. But even when one accounts for the donations, it's true that inevitably there is some level of waste in the system as well, or some level of corruption, you could call it. And sometimes distinguishing waste and corruption there is a very thin line, right? So it's very hard to distinguish from the other. So these are areas where the problem is that if there is waste and the monies are very limited, that can have huge consequences on the system, right? So I would basically start by making sure that there is no waste. Right, interventions so we should identify where the waste in the system is, right, and try to make possible, changing that. So curbing the triggers that lead to waste. Then increase, of course, the donor contributions. And then when it comes to of course tax revenues, one could always say let's increase tax revenues. But here we are talking about a context where individuals often don't participate in the formal market, right? So one would have to think of taxes that are raised either through consumption, right, or through the use of land. That the local authorities perhaps could introduce. Right, but I would probably not go into income taxes because as we know, I mean the formal labor market is the minority of individuals in the country, right? So I think that those are the limitations. I think that donors have a key role to play, and perhaps I mean here is where the WHO could be more engaged. Identifying what are let's say the 20 key cost-effective interventions that then donors could potentially fund, right? And then on top of that, each local authority could top up. So that would define the basic health system, and then the local authorities could top up that basic package of services, right? That would be my take. But yeah, I mean, there's no magic solutions here. I mean, like resources have to come from somewhere. Right.
Sure. Helena, do you want to respond? You looked like you were thinking.
Yeah, I was. No, because surely, and I think to a large extent, money already comes from donors, which can also introduce additional problems, because then the local government or may not be, actually deciding on what to spend money on. And we've seen that a lot in health, because there have been a lot of like one-sided, or one disease focused projects on TB or HIV, while kids are dying from pneumonia, and no one is really interested in that until recently. But sure, I mean, certainly, I mean, this is a really difficult question, and it's I'm sure we're not going to solve it in this session. But I was just curious, maybe you misunderstood my question, because I do think that there is that if you could actually make the communities and the people more aware of what to expect, and kind of ask for more, from their healthcare providers and from the entire system or security system, I think a lot could be gained from that. And I'm not sure if that is part of what you've done, but I was curious to hear whether you have an experience of how to actually, involve the communities to demand more from the healthcare systems.
Yes, I mean, what I would say is some work that we've done on India, right? So we have in India, there's been some local authorities, even villages, I mean, like even down to the village, they've developed councils, which tend to be overrepresented by women, and women tend to have different priorities than men, because in many of these countries, men have, policymakers often have different priorities than the population. I mean, democracy is not, it's hard to measure, but one way to measure democracy is by looking at the correlation of the priorities of politicians and the priorities of the population. And interestingly, women tend to have priorities that are more in line. Women politicians have priorities that are more in line with the priorities of the population as opposed to men. Right? So perhaps having councils with more women and enhancing participation at the local level to make those tough choices. Because I mean, the problem is that in the context of limited resources, one has to make tough choices, right? So one has to decide that this program is very important because of X and Y is not going to be prioritized. And that choice, one could make it at the higher central level or leave it to the local authorities. So different regions would prioritize different programs based on their own needs and preferences, right? We know that are heterogeneous, right? So in some areas, there might be lots of need of maternity wards, whilst in others, they probably have a problem with older people, or they have a problem with cancer and they need more cancer care. So I think I do agree that decentralization and more local level interventions are part of the solution. But there is an issue there with resources that in a context like a low-income setting, or so some of these African countries, I mean, the resources often need to come from elsewhere, right? And I mean, one of the issues here is how to attract resources that otherwise would go to other areas outside health. That's something that we haven't discussed yet, right? So one could argue that there are different priorities across local authorities. So the question is how to steer decision makers to prioritize more health as opposed to other interventions, right? And what we find is that these interventions in India, this local authority, these village council meetings that are more participatory, and they involve a larger share of women and minority groups, they tend to propose interventions, or they tend to prioritize interventions that are more in line with the preferences of the population. So I mean, that would tick the accountability objectives that I just heard before, right? So it's not just about equity, it's not just about efficiency, it's about accountability as well. Yeah, so that's what we know. I mean, I could try to find out other interventions in other areas, but it's important to bear in mind that resources have to come from somewhere, right? So once you have some resources, then the question is how to prioritize them, how to use cost effectiveness, how to regulate for quality. Those are important issues, but they imply the existence of some resources.
Thank you. Ingvar is waving.
Yes, this is so interesting. I'm so happy for us starting to having this conversation. I'm looking forward for many such meetings because it's a fundamental importance. But regarding Homa Bay, and I guess Gordon and Francie will tap in here, because now they have a new governor who has put health as the #1 priority on the political agenda. And health is a broad concept. It also includes food, water, gender equality, and all these kind of questions. So maybe that could be an opportunity to have this kind of political discourse that health should be and need to be prioritized in a broad sense, because prevention from health challenges, not only screening when they become sick, but also prevention will become a part of the whole program, and setting out and working across departments and so on, so try to find or use the resources in a better way. And that is actually what we're trying to do in this partnership, to have a dialogue and in these questions. So, but I really would like to stay into this conversation for a long period of time.
We'll
Because
see what we can do about that, Ingvar.
thank you.
Yeah, because this is just a brief moment together that we have for discussing these very broad issues. So this is more of a starting point, hopefully, for a longer conversation. But I wanted to let Anna perhaps on the discussion. I know you have been actively working with looking at efficiency of screening and looking at how kind of actually from a behavioral scientist perspective, how to structure the healthcare system. Do you have anything that you would like to ask?
Well, not for the moment, since we are still waiting for the full description from the Kenyan side. But maybe I can see that Evelyn has joined us. So if she would like to say something, because screening is one of the things that we will look into more during the visit in April, hopefully, in different ways. We got a chance to see some facilities when we visited Kenya in the beginning of July, and hopefully we will be able to visit here in Östergötland. We have a specific unit which is not a screening unit, which is not at the university hospital, but outside in the suburbs, so to say. And it's mainly managed, with the digital app. Everything is it's like going to the dentist almost. You drop in and you drop out. In the beginning, they also had the drop-in possibilities, but now you have to book a certain time for this appointment to go there. But we will look into different kinds of screening possibilities, and also during the week in April, we will have 2 sessions that are allocated just to look at those 2 descriptions and to see how we can compare and how we can use that, because they are using some kind of special methodology for this. So there will be both a training seminar in order to see how we can use the data that we have, and also how we can make this comparison between the two healthcare processes. So I don't have that much to say. I was hoping that my colleague Peter, who is more involved, would be able to join today, but currently he's on a short sick leave, so that's why. But maybe Evelyn would like to say something.
Yes, we will see if Evelyn wants to speak, and otherwise I'm sure perhaps we can give the word back to Joan. And you have been provided some material from these partnerships, and you might want to pick up at somewhere. You have kind of thrown out some interesting pointers where we would like to dive deeper.
Yeah, so on the point made before by Ingvar, the idea of social determinants of health, right? So health is not just something that is affected by the health system. That's something that we know. So if the goal is to improve health, one needs to do much more than health. One needs to improve environment. One needs to prioritize environment, social justice. We know that inequality creates mental health problems. So social determinants of health are increasingly pointing out as relevant. So corruption, we know that corruption is detrimental for health, right? Because it basically drains resources from the health system, but as well from other areas. And as a result, that means that there's less available to invest on health. But I think that altogether, the pandemic, the COVID-19 pandemic has highlighted the importance of investing in health. So I would say two things. One is the importance of investing in health. Health is part of the production function of any economy, right? So in the past, people would education, capital, labor market, fine, but now health, I think, is part of those inputs, right? And then trust, the importance of government trust, and that's where the local government can play a role, because people have higher trust in local governments than they do in higher level governments, right? Because you can trace them, you can see what they are delivering, right? So I think that the problem in the context of pandemics, for instance, or when there is like a more of an environmental, wider level global problem, is that it requires cooperation. So perhaps one of the things to add to those recommendations is how to enhance cooperation between local authorities. Right, and there are different ways to go. So one could create assemblies of local authorities. Then another important point, I don't know whether you've touched upon it in other sessions, but it's access to water. Hygiene, right? Hygiene is very important for health. So these days we know that, for instance, dental hygiene is responsible for a number of conditions, right? So if individuals don't brush their teeth, or they don't keep their dental hygiene, that has knock-on consequences later in their life. Hygiene generally, and access to water is fundamental, because if you don't have access to water, you often don't clean the food, and you are more exposed to, let's say, viruses and generally speaking, any kind of condition. So the idea is that access to water could be one of those interventions, more along the lines of infrastructure and transport that we were discussing before, that could be prioritized. And then another issue, I don't know, again, whether it's been discussed in other sessions, is the use of traditional medicine. So in many of these societies, people trust more the healer, the community healer, than the hospital that is funded by some kind of foreign aid. They might see them as foreigners, or as selling or as representative of a pharmaceutical industry, which might not have much of a reputation in these countries, right? Whilst traditional medicine has certain name, even though often doesn't do much. So perhaps one way to go would be, and that's what I've been recommending to other governments as well, is to try to work with the healers. So try to incorporate the providers of traditional medicine into the health system. They do it in Korea, they do it in Japan, right? So that when, for instance, what's happening in Malaysia, for instance, a student of mine is heading a behavioral insights unit in Malaysia, is that people, they consume traditional medicines when they have cancer, and they die as a result, because traditional medicines do nothing for cancer, right? So what they are doing now is they are paying healers to refer back to hospitals any patient that comes up with symptoms of cancer, right? But that only happens if they integrate the traditional medicine healers into the health system, which typically many countries don't do, right? So it looks like traditional medicine providers, right, should be part of the system and should be incentivized to collaborate with other kind of providers, right? Because traditional medicine can be effective for some conditions, but clearly is ineffective for others, right? So yeah, and I fully agree that prevention is something to prioritize, is the cheapest possible intervention, right? So making sure that conditions don't emerge. So for instance, in most Western countries, we have a huge epidemic of obesity, right? So that will create huge a series of problems amongst individuals in later life. So preventing in lower income countries, it would be more like smoking. I mean, right now smoking is on decline in most Western countries, but is actually on the rise in many low income countries. So I think that is something to point out, that there are a number of let's say, unhealthy behaviors that if they are not tackled, they will imply a rise in healthcare costs in the years to come, right? So one way to keep the healthcare costs down is to invest on public health, basically, right? So on prevention. I'll stop there.
Thank you. I'm trying to summarize your thoughts into notes. Does anyone else? Oh, Anna, please.
Yes, I have a question, and I think maybe also Region Västerbotten and Region Stockholm has the same, because they looked a bit concerned as well, or I might not have grasped it correctly. But what you basically are saying, I can understand that, because this has been a discussion in our partnership as well, the problem with the health-seeking behavior, that they go to healers or traditional medicine at first. But I think, as a representative from the public sector, spending public tax money on healers in order for them to have the first go or analyze, and to tell the patients to go to refer them to a hospital. I can understand that might be the what do you say, like a one-stop shop, that's where they go first. But I can also see the risk of the, what do you say, the trust for public institutions to link and to pay for this kind of services. That was just, you know, I think that would be quite impossible in many ways, and I'm not sure that would increase the trust for the public hospitals. I don't know if my Swedish colleagues have something to, but I think it's an interesting discussion, because we've been discussing just this, you know, how to, in terms of awareness raising, in terms of communication, where do people go? Where can we, you know, distribute information, like in shops, or when you visit your hairdresser, or, you know. So I think that's something really that we have been discussing, and it's also very challenging, since this is causing a very late diagnosis in stage 4, for example. But still, it's really tricky, and I think this. But this is also what makes it so interesting, this democratic aspect, and that we can see that there is a low trust, and if you seek health for 6 or 7 times, and that's when you get your correct diagnosis. It's of course it's a huge problem, but it's also very tricky, I would say. Thank you.
Yeah. So just very quickly, just to add to this point. So the idea is that the trust is already in the hands of community leaders and traditional medicine healers. So that's not going to change probably in the years to come. So what you can do is build on that. So say, okay, we know that if somebody has cancer, traditional medicine is not going to do anything. So let's actually collaborate with the healers. That doesn't mean paying the healers directly or transferring public money. It's just like making sure that the healers actually manage to refer patients that they see that they have symptoms of cancer. Right?
Yeah. Okay, but the trust issue, it's tricky.
It's tricky, yeah.
Okay, Ingvar has raised your hand.
Yes, a short comment on this. One of our resources and experts is Ann Uma from Kenya. She's contracted as a research and development advisor to Center for Rural Medicine. She's also affiliated to Department of Epidemiology and Global Health. And she has researched on these linkages between the traditional and the formal public education. It's also a cultural aspect. So I'm very glad that Joan raised this potential. And this is something that I guess we need to talk about in the Swedish context for us being able to be a partner, because that's a part of the setting and context. And we also see a lot of good examples in the communities, villages, on how they support each other to assess the situation and do the screening and so on. Even they have little resources in the local context. So there are systems that are in place already that we need to know more about, not coming in with our solutions without not being sensitive what is going on in the local context. So this, but just reflection, and I guess Anne would like to join sometime in this discussion.
Thank you. I'm wondering how to spend the last 5 minutes of this. I think, Joan, you mentioned in the beginning, you started talking about maternal health and that being a good indicator for quality of care, and that you had read the quality of care assessment that I sent you from the Region Stockholm Ginger Partnership. Is there anything else there that you would like to elaborate on?
I would say that there are some interventions. Right? I think that I would look at WHO a list of interventions that are particularly cost effective, and anything that around maternal care would definitely be one of them, right? Another thing is, of course, like essential medicines, right? So there are a number of medicines that are particularly value for money, right? So and hopefully you would have expected that every local authority would have access to those essential medicines. Right, so those are kind of obvious things that everybody would probably have already in mind. But I do agree that the perspective adopted here around decentralization and the building trust, this is fundamental, because I mean, what we are seeing already, for instance, in Britain, is that people that are left behind by the health system are those that are not taking up the vaccines, right? So in the context of COVID, they are not taking up vaccines. So for instance, Afro-Caribbeans or Eastern Europeans in Britain are the least likely to vaccinate, right? And that is because they don't trust the system. They've been traditionally left behind. So one way to improve actually equity would be to look at which are the communities that are traditionally been left behind. Those are the ones that are less likely to engage with the health system, right? So prioritize them, and this would reduce, let's say, equity concerns, would improve the equity of the system, and at the same time, because normally those communities are the ones that are less likely to engage, they are the ones that are less likely to undertake screenings. So it's all part of the same system, really. Right, so building trust seems to be like at the core of any kind of strategy that they are probably having in mind, I would say. So yeah, so that would be my final comment, basically, unless you have something more specific for me to discuss.
No, thank you very much for spending this time with us. It's been great, and it's not an easy task to have 3 different partnerships with different challenges to all perhaps try to give everyone a little something food for thought. But we're hoping that you could send us a little bit of reading material after the meeting is done. And so any recommendations that you have picked up based on the discussions that we have had today and on the material that I sent you before that could be beneficial or a way forward for our partners, that would be greatly appreciated.
Brilliant.
Otherwise,
yes, I'm happy. I'm happy to send to circulate a few papers. Some of this is material I teach, so it'll be very straightforward.
Perfect. That's great. Otherwise, we are going to round off this session. And does anyone have any final comments? If not, there's one new message. Sorry. Yeah, there are some thanks going on in the chat.
Thank you.
Okay, so we will say a great thank you to Joan. Hopefully see you later or see you soon. And to the rest of the group, I would just ask you to stay 1 more minute and I will tell you one last thing. Robin, could you care to share the final slide of our presentation?
Yes. Oh, that one. Are you oh, wait.
Oh, yeah. Move on to the end. Sorry. Or the second to last picture.
It's lagging a little bit.
Here we go. So I just wanted to tell you about what's next. Apart from what is already ongoing, what you are in charge of yourselves to plan peer learning and different exchange visits. We are also planning, we can see your chat now, Robin. We are also planning for a live conference. So we would hope to meet you all live in the fall. We have discussed a few dates with some of you, and our the latest bid on dates is week 41, 9th to 13th of October. Not all of the days, but maybe 2 or 3 of those days. And we are hoping that we will be able to meet in one of our East African partners' home municipality, because we would like to combine the ICLD program with perhaps getting some insight into what is going on in the project, and a more hands-on maybe site visit would be great. So that we will get back to you with more information on this, but if possible, block the week 41, 9th to 13th of October in your calendars, and we will continue the conversation. Okay, we have reached the end of our meeting. Here is a fancy picture of me and Robin with our contact information, and a big thank you to everyone. So glad to have you on board today and always within the partnership program and the network. So feel free to reach out to us if you have any questions, or if you want to continue, pick up a thread from today. We're always available and happy to help. Okay, thank you everyone, and until next time, take care.
Thank you. Bye-bye.
Bye.
Thank you.
Thank you. Bye.
Recording.